All right. So I think we need to start. Good morning to you all. I would like to say thank you so much for making time to attend. And I would like to also express our gratitude to the special guests we have made it into this meeting. Mr. Zimono, thank you so much for joining. Dr. Mangiza, thank you for joining. Dr. Stevenson, and of course, our colleagues in fetal medicine, thank you so much for joining, and all the rest of the colleagues. I see our obstetric colleagues are in the meeting. From Dr. Fungai Miyoshed, all the way from Namibia. Thank you so much for doing this. And Dr. Georgievich, thank you for the amazing support that you give to fetal medicine, Dr. Kunaka, and Dr. Zakazaka Chikwema. Thank you so much for doing this. So what we are going to do is, I will just show you our data, to just show you what is happening, our updated data. I think we showed our data in one of the meetings some months back. But we just want to show you some of our updated data on twins, which I will quickly take you through. Then my registrar will present a case which we can discuss. Probably we will come up with some discussion points on the case. And the good thing is that the team that looks after these babies is here. So to just make it aware to everyone that indeed twins do exist in Zimbabwe. Of course, it looks like it's obvious, but it's something that sometimes people take for granted that twins are there, but we want to show you the numbers as we saw them in the fetal medicine unit at Sale and Perinatal. So this is how common the twins are from our cohort of twins. You can see that they make about 6% of the patients we see in the fetal medicine unit. Up to date, we've seen about 10,215 women in the 2 units, and 6% of them are twins. And in terms of chorionicity, this is what you have to know, that 73% of our twins, which we see, we were certain that they were dichorionic, and only 18% were monochorionic. The 9% couldn't be properly assigned chorionicity during the scan because of late presentation. So out of the 583, we couldn't correctly assign chorionicity, which is a very big problem for us, because the management of twins is determined by the chorionicity, and the outcome of twins is also very heavily dependent on the chorionicity, whether they share the placenta or they don't. So that means we always find ourselves managing women as mono. If we can't diagnose it increases unnecessary burden for review for these women. So, and this is just the outcome of some of the outcome data we have. Our outcome data really, it does not speak much volume as far as the twins are concerned. Probably it's data we need to relook at, because for the outcomes that we managed to get here, so you see that 412 of the women had alive babies out of the dichorionic and the monochorionic as such. It doesn't speak much. It's a data we need to really look into and revise, because the language of this data is suggesting that we are doing extremely well, but we know that there are some hidden dates which were fed into probably get out of the full data set. But this is what we are having in terms of the outcomes. Then in terms of the complications, I've just summarized some of the complications. These are absolute numbers to just show you amongst our 573, if we classify them according to MCDA and DCDA, you will see that the MCDA will give us more of intrauterine fetal demise in both twins. And out of our data set, we saw that we had 6 cases of twin-to-twin transfusion, which would translate probably to close to what? 1% there, which we thought is probably grossly underreporting, but this may be hidden in this number here, intrauterine fetal demise of both twins, because TTTTS is the one that does this more common than any other twin complication. So babies who come to us already dead, both of them, we think these are late diagnosis of TTTS, which are missed cases. So that may explain why we are having what looks like fewer numbers of TTTS. TTTS is expected to be between 10 to 15% in a twin population. So you can see ours is low, but if we factor in the fact that this the twins were 118, so that will mean that our twins, if we just factor in the monochorionic, they are about 5 to 6% of the monochorionic pregnancies. That is, if we don't include the intra-uterine and fetal demise of both. Then in terms of discoding for fetal anomaly, I think we have one case we are going to present where we thought there was discordant fetal anomaly in mono, but the most cases of discordant fetal anomaly whereby one twin is a fetal defect, we saw this in DCDA pregnancies in about 14 of the cases, which will make up something like 2% of our cohort. Then in terms of the TRAP, we had one case of TRAP, TTTs, I think we underreported there, but we had these cases and we had conjoined twins in both twice. And unfortunately, both these conjoined twins demise. One of them was born alive, but demise before intervention. Then the other one had, both of them had preterm birth and unfortunately demise, both of the conjoined twins we saw. The one which was operated by the pediatric surgical team, I didn't include it here. I'm not sure if it passed through us. Maybe I didn't include it there, but that one, if we include it, that will make them 3. Then these are the overall outcome, which I've already summarized before. Then in terms of the mode of delivery, to our obstetric colleagues, I think we have improved a lot how we manage twins, because before twins were being induced a lot. Sometimes we're being induced or allowed to go into spontaneous labor, but due to the work that is being done by the fetal medicine unit, you can see that we have really improved, and only 20% of the monochorionic twins are being allowed to deliver natural, and 0 have been induced from our database, and 35% of the DCD. The rest were being sectioned because we are picking up the selective fetal growth restrictions, and we are recommending C-section for these twins to improve the going home rate of these babies, because twins were not doing well in our institutions. So this is encouraging. It's not a bad thing. Don't look at it as a bad thing and say, are we over-sectioning them? For twins, we are not. Because most of the twins invariably have some problems. You see on the FGR data that quite a number of them will have some selective fetal growth restriction. All right, so this just show you the reason for neonatal admission. Most of our babies were being admitted because of FGR, fetal growth restriction. Of course, 75% to 25% from other causes. So fetal growth restriction is something that is very common. I'm happy the pediatric colleagues are here, the neonatologists. The question is, are you guys capturing the FGR index on your side? Because we feel it's being underreported from the pediatric side. So I think it's something we need to discuss in this meeting. So this is just show you the FGR that we had quite a number of FGR, 177 of our babies had FGR, which make up more than or close to 30% of the twin population we had. So FGR is very common. It's very common. We had less numbers here, which was about 20-something twins. But if we look into the 100, that means twins between 18 and 22% of our monochorionic had fetal growth restriction, either this is fetal growth restriction for both, whereby 6% of the monochorionic had fetal growth restriction both, and 11% in one of them, then 76% for single fetal growth restriction, for selective fetal growth restriction in DCDA, and 7 for both. So fetal growth restriction is very common in twins. It could be both or it could be double. But selective fetal growth restriction is more common in twins. It's something that you have to watch out if you have twins. The thing with twins is, no matter if you're a good clinician and you have good clinical skills, there's no way you can tell the woman that, look, I've examined your baby carefully and your baby is okay in terms of growth, because there are 2 babies in there. So what we have just shown you is what has led us to we managed to pick this through this kind of protocol. My God, I picked up the DCDA. I'm sorry about this. The MCDA protocol is different from this one. basically we do the same things here, but from 16 weeks we start to monitor for TTTS, selective fetal growth restriction, and also TEPS for these babies. So we do scans 2 weekly from 16 weeks for the monochorionic. I'm sorry I picked the wrong protocol there. I thought I was going to share you the right one, but I can still share the right one with you. I think it's important because it will affect our discussion. Let me go straight to it here. Did I change? Okay. Let me just stop the share here, then quickly just show you before my registrar presents to you so that we, right. So I think I'm sharing the screen. So I'll show you the monochorionic protocol. So this is the monochorionic protocol we use. So when twins come to us at 11 to 14 weeks, we do all this. We do dating, chorionicity, aneuploid screening, and labeling of twins. But twins have to be labeled for follow-up. You have to know who is twin 1, who is twin 2. Of course, some is twin A, some is twin B, but the message is the same. Twins have to be labeled. Then from 16 weeks, then we begin to look for TTTS. So we compare the amniotic fluid of both twins and we do the fetal Dopplers as early as 16 weeks. Then 20 weeks to 23 weeks, then we do the fetal anomaly scan, where we do the amniotic fluid and the fetal growth and also the fetal Dopplers. Then every 2 weeks from the 20-week scan, screening for TTTS, TEPS, selective fetal and selective fetal growth and also preterm birth. I'm sorry, I left cervix here. We check cervix at every appointment because preterm birth is very common in our twins. I didn't show you the data for preterm birth. I think it's data we still need to carefully examine, but I'll share with you in another presentation, or my colleagues will share with you in another presentation. So then we recommend that they be delivered between 36 to 37 weeks. This is due to the available evidence at the moment that if you allow twins who are monochorionic to continue going on after 37 weeks, you increase the morbidity and the mortality for these twins. So this is how we are managing twins. Unfortunately, the median gestational age for our twins is around 30 weeks, 30. So you can see the difficulties that our national care protocol puts twins in, because the message is not clear out there what to do with twins, because the national protocol itself is very silent on how to look after twins. It's something that we have to change so that it speaks in loud volumes how twins should be managed. So I'll give this time to my registrar to present. Let me stop my share, then he can present a case we co-managed. I think every guest in this meeting was involved in the management of this case. So just give us a second as we share his screen. Good. You can skip them, right? It's already. So into the mouse. Okay, we are good now. Right. So we'll share his screen so that we can move on. Right. Slideshow here.
Okay, good morning, everyone. I'm Dr. Chirume, the registrar under the fetal medicine unit. So I'm going to present our case. As you have heard from Dr. Verenga, that whenever we are scanning these twins, it's no use when we don't mention the chorionicity, because all the management will depend on the chorionicity, even the complications, as well as the prognosis. Let me try to share my slides. Can I confirm, are they visible?
Yes, Doc.
Okay.
Yes, Doc, but it's not in slideshow.
Slideshow. Okay, let me try to put them on a slideshow. All right.
Are we still in the meeting? Oh, yeah.
So maybe the slide. Try to. Okay, or let me try to use the other laptop because I think that slide was still there. I'll try to use another laptop to present, so that at least we are on time.
Please go ahead.
So let me try to log in on another laptop.
Come on, where's the meeting?
Oh, maybe we can log off. So we're trying to log off with another laptop, because I think we are failing to.
Where is our meeting? I can't find it. Can you return to the meeting? Okay. I think we are okay now. This one, right? We're sorry about the technical glitch. We're just sorting it out now. We're just facing a technical glitch, but we are overcoming it. Sorry about this. Okay, I need to close this one. Are you seeing the screen now, written Dr. Chirume?
No, we have the previous screen that's not in slideshow.
You have the previous screen. We are going to close the previous screen. You have Dr. Chirume's written Dr. Christopher Chirume, right?
Yes.
Ah, okay, okay. Slideshow now.
Okay. That's fine. Sorry for the technical challenges. I think we had a problem to sharing and stop sharing. So I think now we are good to go. So I'm going to present a case of monochorionic twin pregnancy. So these ones we've already covered through, so I won't waste time on this one. So I'll just go straight ahead to the head of the animal. So I'm going to present Mrs. MN, a 36-year-old lady, the housewife, was now in a third pregnancy with the 2 previous miscarriages, which occurred at about 8 weeks of gestation. And we're not quite sure of the circumstances around those miscarriages. She didn't have any chronic illness, no diabetes, and there was no family history of twin gestation. She was referred to us at 32 weeks of gestation for proper assessment of this twin gestation. As she had a prior scan where they noted that there was polyhydramnios, and they wanted further evaluation of that polyhydramnios, which was there in one fetus. So initial assessment at these 32 weeks, I'll just go straight ahead to the main points because we are running out of time now. So here we can see there, even someone who's blind can see the depth of those amniotic fluid. I try to compare them. That one for the first twin and that one for the second twin. We had that we need to label these twins quite well. We usually say the one on the right is the first one, and the one on the left, the second one, or the one closer to the cervix as the first one, and the one distal to the cervix as the second one. So we can clearly see there that the amniotic fluid, there was quite a difference. You can see the depth for the one on the left, on my left, more than 8 centimeters, the single deepest pool. We use the single deepest pool for twins. We don't use amniotic fluid index. And you can see on the left there, quite severe oligohydramnios. You can see the discrepancy there. So we can only able to see things which you know. That's what I can say at this point in time. Which means after having the knowledge, that's when you can really appreciate these differences on both twins. Now, if we went on further to assess these fetuses, if we find that the amniotic fluid for the other one is a poly and the other one is an oligo, the next thing is to look at the bladder, right? The other picture for the other bladder, it was quite a collapsed bladder. There was no measurable bladder there. I should have put a picture to just show you. But this was the bladder for the other twin. We had polyhydramnios, which was quite enlarged. We only know this after we are trying to assess the level of the TTS in these twins. Now, going on to the growth, assessing the abdominal circumference for the twin 1 as well as the twin 2, right? We can clearly see that the measurements were quite different. An AC of 20 and the other one had an AC of 24. Both of them were below the 1 percentile for the stomach. Okay. And also there was no stomach bump. So let me go ahead to assess the difference in terms of the mid-cerebral arteries, right? So we are trying to assess some of the complications which we get from these monochorionic twins. We know that there's TTS. We have already been told about the TTS, and we know the classification of the TTS, where we say if there's a discrepancy in the amniotic fluid, that's a class 1. If there's now discrepancy in the bladder, where there's a full bladder and the other one not a full bladder, that's a class 2. And if you go on to the third grade of TTS, where you're now having a difference in the Doppler flow, and we can now go to the 4th, where you got fetal hydrops, and the 5th, where there's intrauterine fetal demise. So whenever we see a discrepancy in the amniotic fluid, as I have already mentioned, they will now be going through our mind to say, what stage of TTS is this? I know there are a lot of classification which are used, but the quintiles classification is the one which try to have a bearing in terms of how we manage these patients. So if you go on to look at the Doppler now to say, is this now a stage 3, or we're also talking of twin anemic polycythemia sequence, we can clearly see that for the twin on the left there, if you look at the MCA there, right? The peak systolic velocity there, 75, as compared to the one on the right, which is 42, right? And with that, we can still go ahead to use the program on the net, where we are trying to look at what are the multiples of medians from these mid-cerebral arteries, right? And we can clearly see that for the one on the right there, there's increase in the peak systolic, which usually show that there's fetal anemia on the twin on the left side, as compared to the one on the right, where there's a reduced PS, which means there's polycythemia on that fetus, which means on this mid-cerebral assessment alone, we can tell that now there was twin arterial, there was twin anemia, polycythemia syndrome from these measurements of the mid-cerebral arteries. Now we went on further also to assess, we also assessed the cervical length. I think I missed the picture there, but the cervical length was, we would also assess whether there's a high risk of having a preterm delivery with these twins. It was quite a normal cervix, measuring about 3.2. So I just went on to the specifics in terms of the difference for these twins, and leaving the rest of the examination, since we don't have time, so that we can quickly go through the case. So we can see there, initially, amniotic fluid difference. The next thing, the bladder difference. The next thing, the Doppler difference, and also evidence of twin anemia polycythemia sequence. So at this point in time, the mothers, the parents were cancelled of the findings to say, look here, we got TTS, Quintero at least stage 3, and also got twin anemia polycythemia syndrome. And we are at 32 weeks. So the parents were cancelled together. The neonatologists were in the presence, trying to see the best way we can deliver and the time at which we need to deliver these twins. And they were subsequently delivered and were managed by our neonatologist colleagues who are here in this forum. At this point in time, I would want to at least pause and try to invite questions in terms of the ultrasound scan features which were seen on these twins, if there are any questions, so that I can proceed.
Thank you very much. It's Dr. Stevenson. Can you go back to the one with the abdomen? You just mentioned no stomach bubble was seen.
First one. For the abdomen, okay. Okay, this one. Okay.
Can you just extrapolate on, firstly, where we're assuming one has a stomach bubble and the other doesn't. Can you just show that to us and just tell us about the implications of this and which twin is which? You're muted.
Okay, so if you are to look at the small twin, this one, right, where the abdominal circumference is 20, right, we still remember our landmarks for measuring of the abdominal circumference, right, where we say there should be a vertebral body, the adrenal gland, and the hepatic, as well as the sinusoid. You can see there clearly on the left there that these features, we are not finding the stomach bubble as compared to the picture on the right, where we clearly see the stomach bubble down there. I don't know if I answer you quite well.
You have, thank you. I'm just obviously not familiar with your images. So that's the vertebral body. Can you just show us again the vertebral body, the adrenal gland?
Thank you, Doctor, for that. So if you are to look on the picture on the left there, that's where you can see your triangular vertebral bodies. And on the right there is your vertebral body, right? And these things which looks black there are your adrenals.
Sure. And did you label the small twin, twin 1 or twin 2? You're on mute again.
So we label the twin 1 is the blue one. This was the blue one, which was in blue. That's the twin 1. Then that's the twin 2.
Thank you.
I can see your hand is up. Dr. Drew, you can go ahead. Okay.
Yes. Good morning, Dr. Chirume.
Hello. Thank you. Good morning, Dr. Drew.
Yes.
You can go ahead.
Thank you very much. I just wanted to follow up on what Dr. Stevenson was asking. Are we assuming, therefore, that the blue is still the same baby who had polyhydramnios? Or is it just the labeling of the slides? Hello? Hello?
Oh, hello. Yeah, I can hear you, Dr. Drew.
Yes, I was saying.
Okay,
could
that's
you
the correct.
Go back? Which twin is which twin here? Because
all right.
Are we saying that the blue one is still the same one who had polyhydramnios on these images that we are showing on the screen currently? Because I'm still trying to wrap around. Hello?
Yeah. Okay, go ahead. Finish first so that I can go ahead.
Yes. I wanted to find out whether, so which one was the growth restricted twin in this case? Or the one who had oligohydramnios? Is it still the blue one on these images? Because to me, I think that would be a sort of a bit of an anomaly to find the one with polyhydramnios as an empty bladder. I don't know whether it's my reading of the, or could you please just maybe explain to us which one is which twin here? Because I think you could have probably reversed these twins probably when you're presenting. I'm not so sure.
All right, thank you, Dr. Due. So I would want to say both of the twins, they were growth restricted, right? Both of them, they were growth restricted. Then when we scan, we also put color to the twins. Yes. Say twin 1, we used the blue. Then twin 2, we used the brown one. Yes, in literature, we know that for the twin that's receiving more blood is the one that is supposed to be larger, as well as producing more urine, like to have polyhydramnios. But also, let me try to show you some of the literature Okay.
Yeah, so Dr. Dube, I think your answer is correct. One of the reasons why we presented this case is that there were a lot of paradoxes here. Look, this is the same twin, because what we do when we scan, we try to label these twins, not only by their side, but by also the color of the gray scale. So where we put different colors so that we don't forget when we look at the image. So this is the same twin with the bladder here. But this twin, unfortunately, didn't show us a stomach. So we're still dealing with twin 1 here. So this twin was small because, look, I think the neonatologist will give the time to the pediatric surgeon, the neonatologist, to describe their postnatal finding, to just show you some of the complexities that we come across in dealing with these babies. So indeed, this is still the same twin 1. We had this bladder, but was smaller than twin 2. Twin 2 didn't have a bladder. And if you look carefully, you'll see that there is a membrane. Twin 2 had a membrane stuck to it here. So this is where we came up with the diagnosis of TTTTS, which we thought was a valid diagnosis, supported by the taps which we saw on the MCA there. So you can see a membrane. This is a membrane literally attaching to this twin. So correct, the images are what they were when we scanned the patient. So this twin who looked like the recipient is a smaller twin. It's not uncommon. It's also reported in the literature by others that sometimes you have the recipient being smaller than their donor twin in case of TTTs. We didn't emphasize on selective fetal growth restriction, but it is present for both twins. They were fetal growth restricted, but twin 2 was affected more. But whenever you are faced with TTTS and selective fetal growth restriction, the domineering diagnosis becomes TTTS because it kills acutely. It's the dangerous disease between the two of them, the most dangerous disease between the two of them. Yeah, I don't know if I clarified.
Yes, thanks a lot. It seemed paradoxic to me, but I think with your explanation, I'm comfortable with that. Thanks a lot.
Maybe we just answer another question in the chat box. Dr. Ndagura was directly involved in the management of the case. Do you want to come in, Dr. Ndagura?
Yes, Doc, thank you. I think what I can add is that both babies were very small right from the word go. I think I started scanning them at around 14 weeks. They were really small, but twin 1 was smaller than twin 2. At that time, there was no discrepancy in the amniotic fluid volumes or the bladder volumes. And twin 1 also had abnormalities in the umbilical artery Doppler studies. I think Dr. Chris forgot to put that slide. So it seemed they had selective fetal growth restriction right from the onset. And then TTTS then came up later on, as well as TEPS as well. Also, just to mention that before 20 weeks, the stomach bubble for twin 1 was actually visible. And then when they were scanned later on at 32 weeks, the stomach bubble was not seen. I think that's what I can add.
Thank you so much for that. To just answer Dr. Miyochat, say what we normally do with twins. In the case, for example, this case, if indeed the cervix was open, we're going to do amnio drainage because we do know that is due to over-distension due to the polyhydramnios. But in a case where there is no evidence of over-distension from one thing or another, we normally put them on progesterone. I have co-managed together with colleagues, twins who have put sacklages on. I know it's not recommended in the literature, but sometimes that's the best people could offer these women. So I've co-managed women with twins who have had sacklages put, and they've done very well, twins with sacklage. Right, so we wanted the Dr. Mangiza and maybe Mr. Zimuno to comment on their postnatal findings. Because the babies were later on, they were reviewed once. I think Dr. Ndagura reviewed them once after I had seen them. and they went on to be delivered following, because there were signs of deterioration in terms of the Dopplers, and they got delivered. And Dr. Mangiza, the neonatologist team of Dr. Mangiza, Dr. Stevenson, and Dr. Madzuzo and Mr. Zimunu's team, is they are looking after the babies. Do you want to comment now on your postnatal findings? Of the two babies? Maybe we can start with the neonatologist.
Hello, can you hear me? Hello, can you hear me?
Yes, we can. Please go ahead, Dr.
Hello, okay. All right, Lisa. So the twins were delivered about a month ago. I received a call from Dr. Verenga and also from Dr. Ziki, informing me about these twins who had twin-to-twin transfusion syndrome and CAPS, and we were told they were being delivered at about 33+3. They got some steroids almost about 24 hours before the delivery, but we were told the delivery was imminent because there were abnormal Dopplers in twin one. So there was fetal growth restriction in both twins, but then one was worse than the other one. And also that one now had abnormal Dopplers. So we prepared for the delivery and we attended the delivery because Dr. Mazuzo and I, who attended the delivery. So for us, we label twins depending on which twin comes out first. So the bigger twin came out first, came out at 33+4 with a birth weight of 1.6 kgs, had normal UPGAs of about 8 on 10, had a bit of respiratory distress, and we started giving CPAP in the delivery room, and we admitted the baby to NNU. The twin 2, which was the smaller twin, was received by my colleague, Dr. Mazuzo. He was smaller, he was 930 grams. And he required resuscitation at birth. Initial UPGA was low, but by 5 minutes responded to the resuscitation that he received. And the smaller twin looked pale. The bigger twin looked obvious at the time of birth. Besides, we normally try and feed preterm babies expressed breast milk, especially extremely low birth weight babies, which we had in the twin, because we want to reduce the risk of necrotizing enterocolitis. So we kept the baby's NPO the first day so that we'll just give the mom time to get us some milk. She didn't have milk. But then by the time the milk came in, we started feeding the twins. Twin 1, the bigger twin, tolerated feed very well, but twin 2, we kept having issues with the feeds. Sisters kept telling us that each time we try and feed, the baby starts frothing. So by day 3, day 4, we took x-rays with an NG tube in situ, which revealed that twin 2, the smaller twin, had esophageal atresia and there was no stomach bubble. So it was a pure esophageal atresia. And so we consulted the pediatric surgeons to take over management. And also just to mention that because one twin was pale and the other one was plethoric, we did do full blood counts in these twins, and there was a huge discrepancy. Twin 1 had an HB of 22.5 and twin 2 had an HB of 11. And actually twin 2 ended up requiring a blood transfusion because of the need. He had he needed quite a lot of respiratory support. And then after the diagnosis of esophageal atresia, he also needed surgery. So we had to transfuse twin 2. I think those are the major findings that we found initially, but later on as the days went by, we started noting some dysmorphic features, which we noted in the smaller twin. He looked a bit had an unusual face. His ears looked like they were a little bit lower 38, but later on they said they saw it. We thought it was dysmorphic, but that turned out to be normal. And as of now, the twin 1 has gone home. We discharged him at a birth weight of 1.8, so he's been fine. He's gone home, and then twin 2 is still in hospital struggling. We had to be operated for the esophageal atresia. My colleague, the surgeon, Mr. Simon, talk more about, but I can entertain any questions from you at this point. And my colleague, over.
Thank you so much, Dr. Mangiza. Mr. Azimul, do you want to take over? What type of esophagus atresia do we have here?
Thank you, Dr. Wiringa, and all the presenters. So when we received the call about this baby, there was they had obviously failed to pass the nasogastric tube. It kept on coiling in the neck. And we had a couple of images which showed the gasless abdomen. So putting the two together, it gave us an impression that this child had what we call a type A esophageal atresia. It's also described as an isolated esophageal atresia. So in situations like this, we appreciate that it means the gap between the proximal end of the esophagus as well as the distal end is most likely beyond 2 vertebral bodies, and we'll consider that as a wide gap for primary repair of the esophageal atresia. So our first fallback plan, considering the possibility of a wide gap, the size of the baby we're dealing with, and all the other problems associated with prematurity, we thought the best way forward was to put in a feeding gastrostomy tube, and we feed this baby. Hopefully, when they gain a weight beyond at least 1.5 kgs, we can plan to do the repair of the esophageal atresia after assessing how wide the gap is. In the event that we find the gap to be too wide, then we might have to think of options of esophageal replacement with some loop of bowel. So that's where we are. The child is, I think, has responded very well to the feeds through the gastrostomy tube, and we are just waiting for the pulmonary issues as well as the issues of prematurity to improve. And hopefully once they start getting a gain of weight, we start the necessary investigations for the repair of the esophageal atresia. Thank you.
Thank you so much, Mr. Simon, for that. For the neonatologists, are we planning to do karyotype? What are we planning to do for the dysmorphic baby to find out what is exactly happening to this baby?
I think, let me try and answer that. I mean, part of the question was to you, how sure are you that these are truly monochorionic twins? Because if they are monochorionic twins, it is possible that they can have genetic differences, more likely single gene differences than, like, if we were to see this child as a singleton, we would be expecting a major karyotype difference. I mean, it is conceivable between identical twins, but it would be uncommon. Another possibility, rather than a chromosomal abnormality, is a vectoral sequence, which is not a genetic, a vectoral pattern. It's not a genetic condition. We don't know what causes it and why they happen together. So I think that might be more likely. We have a suspicion that this baby has a VSD as well. So we can do a karyotype, and I think that's one of the questions that I want to take away from this meeting is a microarray or a karyotype appropriate? This family are struggling with money. We don't want to do a $400 or $500 test that's not appropriate, but if we're about to embark on major surgery, we have to think, would the karyotype change our plan? That's another, our management, that's another whole question in itself. So I'm very open to suggestions about that.
I do agree with you, Alec, that it's not common to find discordant fetal anomalies in monos, but it's reported in the literature. You are correct to say maybe karyotype may not yield what you want. Microarray, yes, it could yield what you want, but if resources would allow, I think this is the kind of case which we may need whole exome sequencing to try and zoom in onto the gene arrangement, the nucleotide arrangement itself. So yeah, it's a case that we need whole exome sequencing, not just a chromosome microarray. Chromosome microarray may still leave us with some unanswered questions, considering the dysmorphic features you guys noted, and also of course, the major defect. This probably is more of a syndrome, a rare genetic syndrome, which we may not easily pick with the common gene panels. So, yeah, I agree. If resources are available, maybe microarray with a whole exome sequencing. They are offering it in South Africa. It's just that it costs, I think, between 1,500 and 2,500 US. To do the whole, both microarray and whole exome sequencing. So it's an expensive test, but it's something that people who can afford should be offered. Some few questions in the
Trick surgeons, would it change your management if we find an abnormality, possibly? So when we're doing whole exome sequencing, it's quite likely that abnormality will be of uncertain significance. Would that then change your plan to do an esophageal repair or not?
Thank you, Dr. Stevenson, for that question. I think it touches on a lot of ethical issues, and I would say, for a start, if the child is doing well and we think they will survive, then we are obliged to assist them and do the esophageal atresia repair. But of course, we will need to discuss this with the parents as well as the whole team to see what it means in terms of length of life for the child. I do appreciate that we are out of funds to do a lot of things on the child. The only challenge, if we do not do the repair, is that they might end up getting repeated pneumonias from aspirations. A baby can be grown quite well to beyond 6 months feeding through the gastrostomy tube, but we'll need to think of a plan for the proximal pouch of the esophagus, some form of continuous or frequent suctioning to prevent the aspirations. So yeah, it's a very difficult question, and I think I will fall on the rest of the team to try and come up with the best way forward.
Thank you so much. To be honest, our time is up because we don't want to exceed time, considering all of you guys have things to do. What we are going to do is, I know my registrar wanted to present what he has been reading or studying to us, but we can, this is not the last time to do twins. We are going to do twins more. We'll give him an opportunity to present to us what he has studied, what he has researched on another time, so that we don't inconvenience you guys. So to just answer some few questions in the chat box, yes, we do have CPD points to be given. This is the webinar, so you are already registered. Our staff will send you CPD certificates with this. Then I think there's another question, Dr. D. Do we have a different protocol for IVF twins? No, we use the same protocol even for IVF twins at the moment, because we have not seen the need to use a different protocol for IVF twins. I don't know if there's someone with a different way of seeing things to say we should use, but we've not seen it, that we should apply a different protocol to IVF. I think probably with that, we want to thank you so much for taking time. There's not enough time in the world to discuss about these issues, but we'll be doing this every week. So thank you so much. Panelists, you always be sending an email if we would like you to attend and give us your valuable contribution. But thank you so much for taking time to do this. Then, obstetrician, please encourage high-risk pregnants to get on a good ultrasound medical aid at earliest convenient. Excellent. That's a very important contribution there. Then to just say, look, when we didn't see the stomach, I called my colleague, Dr. Ndagura, who had seen the patient earlier, and said, Dr. Ndagura, did you see the blood, the stomach on twin one? Dr. Ndagura told me, no, I saw the stomach on twin one. And I said, okay, if you saw the stomach, certainly the baby can be having esophagus atresia. But alas, it turns out that the baby had esophagus atresia. So non-visualization of the stomach is a serious issue. What we normally do is that we don't normally panic and tell them that is esophagus atresia. We bring them back for another scan. If we don't see it on the second scan, then we tell them that, look, it is highly likely that you have esophagus atresia, which is not a very good abnormality. As you can see, it's normally associated with other things. But monochorionic twins are special. They have complications. On the pediatric side, I think we should agree that TEPS and TTTS are different. This case, there was coexistence of both TEPS and TTTS. Probably the esophagus atresia was the confounder here, but we are saying there was TEPS. You saw it from the difference in blood, the pink and the pale. The TTTS babies without TEPS are not going to be pink and pale, but there will be some evidence of some mild dehydration in the donor twin and overhydration in the recipient twin if we do the use and ease. So I think those terms should be distinguished even when you teach the young dog, our students, that we have twin anemia polycythemia and we have TTTS because they are different. Thank you so much. Enjoy the rest of your day. Bye-bye.
Thank you.
Next time we'll show you eye drops, Dr. Muyocha. She's asking if we could show eye drops images.